Hi there, I'm Xavier Amatrian. I'm the co-founder and CTO Curai, and today I will be telling you about how we use AI and NLP in approaching our online virtual care in the COVID-19 age. And I will be giving you a little bit of an introduction to what we do at Curai, how do we think about this, using AI to power primary care for everyone, talking a little bit about the research we've done and how we've used it in the context of COVID-19. But very importantly, this presentation should be an introduction to the more in-depth research presentation that our head of research, Anitha Kannan, will be giving to all of you later today. So if we look at where we are in the world, right, and in terms of healthcare and healthcare access, there's like more than 50% of the world that doesn't have access to essential healthcare services. And this is not only the third world or the developing countries. 30% of US adults are underinsured and don't have proper access to healthcare. And there's a shortage of physicians, right? By 2030, there's a study that says that we will be lacking more than 120,000 physicians. So we are just not making enough doctors. We're not creating enough physicians to serve all these needs. And that's, on the one hand, creating lack of access. On the other hand, it's also burning the few physicians we have out. They only have 15 minutes to capture all the information, diagnose, and recommend a treatment, and that causes burnout. But at the same time, it also causes medical errors and a lot of deaths, like over 400,000 deaths a year are estimated to be caused by misdiagnosis. Now, of course, in the midst of all of this, we get a pandemic, right? And COVID has, if nothing else, only exposed even more the deficiencies in the US and the world healthcare system. And a lot of heads have turned to telemedicine, like, hey, what about telemedicine? What can telemedicine do for us? And can it solve all the needs of access and giving people access to medicine? And the problem with telemedicine is that it's just recreating old workflows and all medical habits into a new form. And what we're trying to do at Curai is reimagine that, right? And saying, what if we create an AI-powered learning healthcare system that is able to, in a mobile-first way, provide always-on, accessible, and affordable healthcare? And in order to do that, we need to automate a lot of the processes, right, and make them very streamlined. And we think about combining AI and human providers in the loop for high quality care. And we want to develop a system, we're developing a system that is always learning. And in order to do that, besides the human providers in the loop, we develop AI that is able to operate in the wild. And we'll talk a little bit more about all these concepts and how we integrate all of that into the system. How does this look like in practice? Well, this is what it looks like. The patient view is an application that you can, if you're in California or Florida, as of today, you can download and start using. And it's chat-based mostly. We also integrate pictures, but it's mostly chat-based. And you interact with a combination of AI, clinical associates, and licensed physicians. On the right, you see the provider. What they see is an electronic health record that is integrated into the whole conversation and experience with the patient, but also very importantly, it has a lot of AI power features that enable more efficient, but very importantly, higher quality medical outcomes. Okay, and how do we power all of this experience, and what do we do? How do we use AI and NLP for this kind of end-to-end service? Needless to say that there's been a lot of work in AI applied to healthcare over the past recent years. We focus on three main areas, and particularly important to this conference on NLP, right? But besides NLP, we do medical reasoning and diagnosis. and multimodal healthcare AI. And here, below each of the categories, you see some of the examples of some of the projects. And I'm going to be talking about some of them, particularly as, again, in the context of COVID-19. The general principles that we use for all our research is this notion of they need to be extensible. So we think about how AI can be extensible and how we can use data feedback loops in order to have systems that learn and have our healthcare system that learns and improve. And how can we use experts in the loop, in this case, physicians in the loop, to improve that learning? The second general principle is how do we combine data and modern AI approaches like deep learning that need large quantities of data, but also domain knowledge. And last and not least, this notion of like, how do we build systems that can operate in the wild so they know when they need to fall back to the physician, they know what they don't know, and they also can predict and anticipate uncertainty in the prediction. So all of those things are combined in different ways in our research and our publications and the work that is very importantly integrated into our service. Here's a list of some of our publications that you can go and check in our, we have a couple of blog posts where we summarize some of these research areas. As you can see, it's mostly a combination of NLP, medical reasoning, and then multimodal AI, particularly with images. Now, I'm not going to go into details of any of those publications because I said Anita Kannan will be speaking about that later today. So I really encourage you, if you're interested in our work, to go and see her talk. What I will be doing instead is telling you about what we did in the context of COVID-19, how we adapted some of the research and some of the solutions we had in the product for this situation. And of course, when COVID-19 hit and we were all happily working in our office in Palo Alto, we had to sort of like very quickly shift our attention to how can we apply some of the things we're doing for this new world and this new situation. And here you see a summary of the different things we did and how we integrated them in the context of the pandemic. And I will talk about a couple of these solutions that we built into the product, but basically this whole end-to-end process of that includes from Q&A and access to information to assessment, including history taking and triage, at-home testing, care plan, and follow-up. And all of it integrated in this end-to-end system that is powered by AI, but has the physician in the loop. So one of the first things we built was a personalized diagnostic assessment. And this personalized diagnostic assessment was basically integrating the best known information as we were going. And if you remember the first weeks and even months of the pandemic, there were a lot of things that were not known, like the loss of smell. It was a finding that came up weeks, if not months later, after there had been some studies confirming that was indeed one of the symptoms. But in any case, we had this personalized assessment that included things like your location, and we were integrating with incidents of the pandemic in different zip codes according to the latest data that we were receiving as we were updating our knowledge base, but also our algorithms and our data. So our personalized diagnostic assessment was then integrated into our whole providers in the loop service and included daily follow-ups. So this notion of like, it's very important here to note, we did not have sometimes people think of this as a symptom checker, but we did not have a symptom checker that would leave you out in the open and say, okay, well, we think you have a probability of having COVID, but now good luck, go figure it out. This was integrated into the whole sort of like end-to-end service where you could talk to a combination of clinical associates and medical providers and go all the way to get a prescription and then follow-ups that were automated and were integrated in the loop, and they were on a daily basis asking you like how the different symptoms were progressing. Now, how do we learn from that? How do we feed back into this learning system, right? So the interesting thing is that as soon as we started having those data points and we started having this automated personalized assessment with providers in the loop integrated into the system, we started having data that was labeled and that could already be integrated into our existing diagnosis models, right? Remember, one of the important things about diagnosis models is that they come up with some form of differential diagnosis, but they need to, if a new disease comes up like COVID-19, they need to all be readapted to account for the probabilities of this new disease being the root cause. So how we did this is we integrated this into our existing differential diagnosis. We presented this last year at the NeurIPS ML4H workshop, a COVID-aware diagnosis model. And this is a summary of the approach and how we do and how we were able to do some of these things. This is actually an extension of a prior work that we did that's called Learning from the Experts, on how to combine expert systems that generate synthetic data with deep learning and machine learned diagnosis models. If you look here on the top, you see that we use an expert system to generate simulated data. Then we combine this data with some other data coming from the real world, like, for example, data coming from an electronic health record. We train a machine learned model, and that machine learned model is the one that we use to perform the final diagnosis. And we show in this original paper that by retraining a machine learning model out of synthetic data, we get better accuracy than even using the original expert system. And we get the benefit that we can inject new data that we have from the system, so we create this feedback loop. Now, of course, we can apply the same method here in the COVID-19 situation, right? And that's what we did. So basically, we use an expert system to generate simulated data. We then introduce the data we were gathering from our service, the COVID-19 assessment data, into a machine learned model. And that deep learning model was learning sort of like the new enhanced differential diagnosis system that now included COVID. And here in that paper, we presented the results that interestingly showed that even some of our systems, as they were, the models that were being trained, were higher accuracy than the average physicians that were reported on the same data set in this paper from Fraser and others in 2018. Here are some examples of a diagnosis before COVID for a certain inputs, with basically had influenza on top, and then an infection and pneumonia, and then COVID-19 in this case came in second place. And here in this case, because there is an introduction of healthcare worker, COVID-19 happens to be, the probability of COVID-19 happens to be in the first place. Okay, now let me give you another example that is more maybe related to the NLP and the area that this conference is focused on. We also build a Similarity question matching system for COVID-19 FAQs. And the idea here is, especially in the early days, we had a lot of people coming in asking questions about COVID-19, and there were questions on the internet about everything related to COVID-19, but it was really hard to know how to navigate those FAQs and how to point the user to the question that they were interested on, right? So we said, what if we actually allow the users to formulate the question however they want, but then we use Similarity model to point them to the right answer, right? And in order to do that, what we did is we use a double fine-tune BERT model. And the way that we did this double fine-tuning is, first we used a domain-specific BERT model to model the probability that an answer A answers a question Q, and then we tune it again on a question similarity task that was not domain specific. So there's two things that here are being tuned. One is the domain, and the other one is the task. So we integrated this into the system, and we did an automated FAQ matching via question similarity. And of course, because we have the provider in the loop, we can also have sort of like the providers vet the quality of the answers and make sure that if we're feeding back data into the system, it's also correct. And here is the system and how it was integrated, and the product in action, and how asking a particular question like, can I go out, was directly leading the user into questions like, can I go to the park? Also, can I order takeout? Can I get on the subway? All of these questions that I forgot to mention were directly coming from a combination of websites like CDC or the World Health Organization, and also developed internally by our physicians. So they were all vetted and good quality questions and answers. So I guess just to finish off, it's important to think about how healthcare needs to scale quite quickly. And this has become even more obvious in a situation like the global COVID-19 pandemic. And the only way that we know to scale healthcare, while at the same time not only keeping quality constant, but also improving it, is by using AI to automate and to make it more efficient, right? But very importantly, you cannot just drop AI in the middle of all workflows and processes and hope that it works. And that's something that we've seen time and again, people trying to build a fancy AI tool, drop it in the doctor's office, and hope that it's going to solve all their problems. What we think at Curai is that we need to basically reimagine the end-to-end medical process and consider the AI as another member of the team, right? That is working hand in hand with providers in order to provide high quality healthcare. And we're very hopeful and also very optimistic that in doing so, we're going to be improving healthcare in the next few years. So I look forward to that being not only possible, but a reality. And again, I would encourage everyone to go and watch Anita Kanan's talk later today to go into more details of our work in NLP and some of the fancy research that we've been doing. Thank you so much.